The last session we spoke about RV systolic function and then the methods that we use to assess RV systolic function. You can do RV ejection fraction using 2D or 3D. It's always best to do the 3D measurements when you're doing, in assessing for ejection fraction. We also look at fractional shortening. That is basically uh, the left ventricular uh, dimension, the left ventricular area in diastole minus the left ventricular area in systole divided by left ventricular area in diastole. So that's a fractional area change. We also talk about TAPSE, tricuspid ulnar plane systolic excursion. It's basically the longitudinal displacement of the lateral tricuspid annulus. And then we spoke about um, RIMP, right ventricular index of myocardial performance, and we went over how well, first the definition of RIMP and what is significant. So the definition of RIMP, if you remember, is tricuspid valve closure to tricuspid valve opening minus ejection time divided by ejection time. So that's RIMP. When you simplify that we get IVCT plus IVRT divided by the ejection time. And then we said that anything greater than 0.4 is abnormal. We talk about RV S prime, that is the systolic velocity of the lateral tricuspid annulus. So those are the methods that we use to assess or evaluate RV systolic function. So you have to know them. Now we're going to go on to the right atrium. So the function of the right atrium, it assists in filling the right ventricle. So the right atrium is like a reservoir. It fills up with blood, and then the blood flows into the right ventricle. If you want to look at the right atrium, you can use your four-chamber view. It's best to use the four-chamber view, and you can do planimetry and get the right atrial area. The right atrium is enlarged if the area is greater than 18 centimeters squared. So the right atrium in terms of area should be less than 18 centimeters squared. All right, there are also some additional measurements in the right atrium that you need to familiarize yourself with. So this is how you do the planimetry. So when you come to the tricuspid annular plane, it's a straight line, and then you just do planimetry around the right atrial border. And you will have two measurements to do, okay? You have from the tricuspid annular plane, you can drop a perpendicular straight down, and you can do that measurement. So this is what we call the major dimension, and then about midway you can drop another perpendicular to the center line, to the major dimension line, and then you get your so-called minor dimension. So these two measurements are important. The major dimension, okay, which is this vertical line, and then the minor dimension, which is about midway, and you drop your perpendicular. So your major dimension should be less than 5.3 centimeter, and the minor dimension should be less than 4.4. Again, it looks like this. So this is your major dimension. So this is your tricuspid annular plane. Major dimension is vertical. Minor dimension is the horizontal. Okay, so we said that the major should be less than 5.3 and the minor should be less than 4.4. Anything greater than those numbers suggests enlargement of the right atrium. And then you have to know the area. Area should be less than 18 centimeters squared. So we, you know, we spoke somewhat about the we spoke about the right atrial pressures. We spoke about the RV pressures and the pressures in the pulmonary circuit. Remember that the pressures on the right side tend to be lower than the pressures in the left side. That's important. Okay. The pressure in the right atrium is going to influence what goes on in the inferior vena cava. And as a result, we use the size of the inferior vena cava and how well the inferior vena cava collapse with inspiration to judge the right atrial pressure. Okay? So we use the size of the IVC, inferior vena cava, and the collapsibility of the inferior vena cava with inspiration. And we're going to give you 3 numbers to remember. So a normal right atrial pressure is approximately 3 to 5, but 3. When we say a normal right atrial pressure, we're saying when you look at the IVC will be less when you measure it. It's going to be less than 2.1 centimeter, and you're going to have more than 50% collapse of the IVC with inspiration. So that's a normal. When you have a normal right atrial pressure, you're going to get those things. And normal right atrial pressure, we usually say is about 3 millimeters mercury. A very abnormal right atrial pressure, when you look at the IVC and you measure the IVC, it will be 2.1 centimeter or greater. 2.1 centimeter or greater. And you're going to get less than 50% inspiratory collapse. So the IVC is going to collapse less than 50% in inspiration. When those conditions are met, the right atrial pressure is 15 millimeters mercury or greater. 15 millimeters or mercury or greater. And anything that falls in between those two extremes, that's a normal and a severe, we say it's moderate. And we give the right atrial pressure 8 millimeters mercury, 8. So anything that falls between the normal and the grossly abnormal, we give the right atrial pressure 8. Okay? So it's normal for the inferior vena cava to collapse more than 50% with inspiration. And how we do the measurement, we measure the IVC just proximal to where the hepatic vein enters the inferior vena cava. Remember that the hepatic vein which courses through the liver empties into the inferior vena cava. Okay? So we call that the sniff test. Okay? So the IVC collapse with inspiration, you can tell the patient to take a deep breath in and see. And it's best to do M mode measurements, guy, because you can see what happens with the IVC with inspiration. So This is your subcostal view. This is the inferior vena cava right here. Hepatic vein is right there. Remember what we said, the hepatic vein drains into the IVC. So just proximal, so the hepatic vein is right there. So just proximal to that, that's where you're going to do your measurements. And again, it's best to do M mode because you can observe if you have that inspiratory collapse. You do your sniff test. So this is the table that we just went over. So a very high right atrial pressure is characterized by IVC measurement more than 2.1 centimeter, less than 50% collapse of the IVC, and then what you get is what we call a restrictive fill-in. If you look at the tricuspid EE prime ratio, the tricuspid EE prime ratio is going to be greater than 6. And then when you look at your hepatic vein, you have a diastolic flow predominance in the hepatic vein. So these are all features with a very high right atrial pressure, 15 millimeters mercury or more. So with a normal right atrial pressure, the range is between 0 and 5, but usually we give 3. The IVC measures less than or equal to 2.1, and you have more than 50% inspiratory collapse. More than 50% inspiratory collapse. And anything that falls in between, we usually give the right atrial pressure 8 millimeters mercury for a range between 5 and 10. So you have to memorize this table. You have to know this table, okay? Because this is what we use in everyday life to assess, because we have to assess RV systolic pressure or the PA pressure, PA systolic pressure. So you have to know this, okay? All right. We went over how you evaluate for pulmonary arterial systolic pressure and the right ventricular systolic pressure. We said that the pulmonary arterial systolic pressure is the same thing as the RV systolic pressure unless you have an obstruction at the right ventricular flow tract or the pulmonary valve, unless you have an obstruction there. The PA systolic pressure is going to be the same thing as the right ventricular systolic pressure. Okay? You have to know this statement. So what we do to assess right ventricular systolic pressure, we look at the TR jet. We look at the TR jet because the TR jet represents systolic pressure difference between the right ventricle and the right atrium. Okay? The reason why you're going to get blood flowing from the right ventricle into the right atrium is because the pressure in the right ventricle is greater than the pressure in the right atrium. In systole, there's a pressure gradient with driving the fluid, the blood that is, from the right ventricle into the right atrium. And your TR peak velocity, when you do your Doppler, you can transform that velocity into a gradient 4v squared. Okay, so just going over the exercise, the gradient is the right ventricular systolic pressure minus the right atrial systolic pressure. That's the gradient because the blood is flowing from the RV to the RA. And again, the gradient is equal to 4v squared. So your TR velocity, the peak velocity, you square it, you multiply by 4, and you get. So what we're saying is that the right ventricular systolic pressure is the same thing as the pulmonary arterial systolic pressure, unless there's an obstruction at the right ventricular flow tract. And then if you're going to do your pulmonary, okay. So again, because it's a Doppler technique, you have to do your assessment from multiple windows, because you want to get your flow as parallel to the blood flow. Sorry, you want to get your ultrasound jet, your ultrasound beam, parallel to blood flow as possible because of that cosine theta. If theta is 90, cosine of 90 is 0. If theta is 0, cosine of 0 is 1. You get your maximum Doppler shift, the lower the angle, or the smaller the angle. You always have to remember, any Doppler technique is subjected to this angle problem. So when you look at your TR jet, so this is a short axis at the level of the aorta. Your cursor is across the tricuspid valve, and you have tricuspid regurgitation. Blood is flowing from the RV across the tricuspid valve into the right atrium. It's moving away from the transducer, so it's below the baseline, and it's systolic flow. So the peak velocity will give you an assessment of the gradient. You're gonna square the velocity, multiply it by 4, and you'll get your gradient. All right, so to get your pulmonary artery diastolic pressure, you have to look at your PI, pulmonic insufficiency, and you want to get your end velocity. You're going to measure the velocity at end of diastole. You're going to square that velocity, multiply it by 4, and you're going to add your right atrial pressure. Because for you to get pulmonic insufficiency, blood is flowing from the pulmonary trunk across the pulmonary valve into the right ventricular flow tract in diastole. So the pressure in the PA in diastole have to be greater than the pressure in the RV in diastole, which is the same thing as right atrial pressure. So we just use them interchangeable. Okay, so this is the pressure gradient. Blood is flowing from the pulmonary trunk across the pulmonary valve into the right ventricular flow tract. The only reason why that can occur is because the pressure in the pulmonary trunk in diastole is greater than the pressure in the RV in diastole. So that you get a pressure gradient. Okay, the RV diastolic pressure is the same thing as the RA pressure. So this is the gradient, and it's the end diastolic velocity. So you square the velocity, multiply by 4, you get the gradient. You have the right atrial pressure, and you get the pulmonary artery end diastolic pressure. Okay, so this is how it's done. Short axis at the level of the aorta, cursors across the pulmonary valve, and you get your PI, you get your early velocity, late velocity, okay, end diastolic velocity, your end early pulmonic regurgitation velocity, and you just square it, multiply by 4, add your right atrial pressure, and you get your PA diastolic pressure. Okay, as I've been saying this, time in, time out. Mean pulmonary arterial pressure is a much better assessment for pulmonary hypertension than just your pulmonary arterial systolic pressure. So mean pulmonary arterial pressure is a better assessment for pulmonary hypertension. And to get your mean pulmonary pressure, it is half the pulmonary, 1/3 pulmonary systolic pressure plus 2/3 the pulmonary artery diastolic pressure. So whatever method you're going to use to get your pulmonary artery systolic pressure, usually the TR peak velocity, 1/3 that plus 2/3 the PA diastolic pressure, and that will give you your mean PA pressure. Or what you can do, you can use the early PR velocity, square it, multiply by 4 at the right atrial pressure. So remember, this early pulmonary regurgitation velocity, you can use it. If you want the mean PA pressure, that's what you're going to use. So you use that, you square it, multiply by 4, add the right atrial pressure, and you'll get your mean PA pressure. Okay, so okay, um, the tricuspid valve. All right, let's. All right, so you have to know the tricuspid valve, and you have to know the leaflets. There are three leaflets. You have to know how to label them because it's fair game for them to throw one in the exam and ask you which leaflet it is. So you need to know how to identify the leaflets. Okay. Um, so let's okay. So the tricuspid valve is situated between the right atrium and the right ventricle. Okay. It consists of three leaflets. You have the anterior, the posterior, and the septal leaflet. Usually, as we mentioned, the pressures on the right side is less than the pressures in the left side. So you'll find that the peak velocity across the tricuspid valve is usually less than that across the mitral valve. And if your E velocity is the largest velocity, it's going to be usually less than 0.7 meters per second. And you will get respiratory variation in your flow across the tricuspid valve. You tend to get respiratory variation. So whether it is tricuspid inflow or TR, you tend to get respiratory variation. So the tricuspid valvular complex consists of the chordae tendineae, usually three or more papillary muscles, and you get your fibrous annulus. So it's usually three or more papillary muscles. Disease that can affect the tricuspid valve, you can get tricuspid stenosis. The valve can be narrowed and don't open fully. So tricuspid stenosis. Rheumatic fever can affect the right side, and you can get tricuspid valvular problem. Carcinoid. Okay, they love this in exams because it's classic. So you have to know about carcinoid tricuspid valvular disease. Tumors can affect the tricuspid valve. Vegetation, especially intravenous drug abusers, and valvular damage from pacemaker leads. The pacemaker lead will impinge and it will press on the tricuspid valve and prevent proper closure. You commonly get tricuspid regurgitation. The Valsalva, aneurysm of the Valsalva can affect the tricuspid valve as well, and prostatic obstruction. If a tricuspid valve prosthesis, it can become obstructed. So, what are some of the signs and symptoms of tricuspid stenosis? Some patients will tell you they have these fluttering discomfort in the neck. And that is because, if you think about it, the blood cannot get out of the right atrium. So the blood backs up, the pressure increase. So the pressure in the superior vena cava is going to increase. So the neck veins are going to be increased, and you'll get this fluttering discomfort in the neck. Patients will complain of fatigue, okay, cold skin, right upper quadrant abdominal discomfort, and that is just because since the inferior vena cava cannot drain freely into the right atrium, the liver becomes engorged, and you'll have hepatomegaly, that is enlargement of the liver, and it will be tender. Okay, so right upper quadrant abdominal discomfort, and jugular pulsation and jugular distension. And you will get so it's a tricuspid stenosis, so it's going to be a diastolic murmur. So when you listen at the left sternal border, usually in the fourth intercostal space, you're going to get a diastolic murmur. Okay, presystolic means diastolic. So it's a diastolic murmur. And of course, anything on the right side is going to increase with inspiration. So this diastolic murmur, when you listen and you tell the patient to take a deep breath in, the murmur is going to increase. Okay. Usually all murmurs on the right side increase with inspiration. So carcinoid is a very common cause for this. So someone with carcinoid heart disease, when you look at the tricuspid valve, it's fixed in position. It's neither closing or opening, but it opens stenotic. So when you do your Doppler, your Doppler gonna show you usually have tricuspid regurgitation, and you also have your tricuspid stenosis. So when you do your tricuspid inflow, you will find that the gradient is in increase, and because the valve is not opening or closing properly, they tend to have tricuspid regurgitation as well. So carcinoid, classic, they usually bring that. So again, you have when you do your tricuspid inflow, you're going to get increased gradient, and that's your TR. Okay. So you can see the atrium is huge. Atrium is huge. And the valve is sort of held in position. It's like a wax. It's like a waxy material that. So tricuspid stenosis, these are the features for tricuspid stenosis. And it's either significant tricuspid stenosis or minimal tricuspid stenosis. So the mean gradient is usually greater than 5 millimeters mercury. This is for significant tricuspid stenosis now. The mean gradient, when you do the gradient across the tricuspid valve, usually greater or equal to 5 millimeters mercury. When you do your velocity time integral, it's usually greater than 60 centimeters. Pressure half time, unlike the mitral, anything greater than 190, greater or equal to 190 millisecond, suggests significant tricuspid stenosis. For the mitral, it's 220, but for the tricuspid valve, 190 milliseconds. And then if the valve area by continuity equation is less than or equal to 1 centimeter squared, then that suggests tricuspid stenosis. So tricuspid stenosis is not very common. However, in exams, they love carcinoid. They love carcinoid syndrome. And because of carcinoid syndrome, they will bring you tricuspid stenosis. And I say it's classic. The valve look like the valve is fixed. It's neither closing or opening. Okay, so the patient going to have tricuspid regurgitation, and when you look at the tricuspid inflow, it's stenotic. All right, so let's stop here, and